Personalized treatment effects equal PET. Professor Kurinchi Guruswamy, PhD, Professor of Evidence-Based Medicine and Surgery, University College, London. There are three major aspects in healthcare of an individual. The first aspect is whether someone has an illness based on observations by patients, carers, loved ones, healthcare professionals, and additional tests. The second aspect is whether the illness requires a treatment. In other words, what are the consequences of not treating an illness? The third aspect is what the best treatment for the illness is. This presentation focuses on what is the most effective treatment for an illness when an illness requires treatment. Before we go on further, it is important to describe certain terms and concepts. What is an outcome? An outcome is a measure used to decide whether the treatment works. Some examples include longevity of life, quality of life, or improvement of symptoms. A short while ago, I mentioned that this presentation focuses on the most effective treatment for an illness when it requires treatment. What do we mean by effective treatment or effectiveness? Effectiveness is the ability of a treatment to improve an outcome. For example, does surgery improve longevity of life or quality of life or both in people with pancreatic cancer? A related term to effectiveness is treatment effect or simply effect, which quantifies how well a treatment improves an outcome compared to another treatment or no treatment. For example, how much improvement in longevity of life or quality of life or both does surgery provide compared to chemotherapy alone in people with pancreatic cancer? The next concept that we describe is shared decision making. Shared decision making is a collaborative process that involves a person and their healthcare provider working together to reach a joint decision about the person's care. There are various models for shared decision making, and the key components vary between the models. The most prominent components in recent shared decision making models include learn about the patient, tailor information, describe treatment options, including evidence of benefits and risks, deliberate, and determine next step. From this, it is clear how evidence and patient preferences and values are key components of shared decision-making process. But what happens in reality in the best circumstances? Healthcare professional is aware of the best evidence. They provide the effectiveness of treatment and alternatives tailored to the individual. They then deliberate with the patients, survivors, carers, and loved ones as appropriate and makes the final decision about the treatment. There are several limitations of this approach. The current approach provides only the average treatment effects. This assumes that the treatment works equally in all types of people included in the research. There is evidence that this is not the case. Traditional approaches using information from a subset of participants similar to the patient are insufficient. There is currently no universally accepted solution. Another limitation of the current approach is that this approach may not take uncertainty in evidence into account. Prediction of treatment effect is based on previous research. However, there are two major errors because of which the prediction may not be correct. The first major error is the systematic error, or the error that arises because of an unfair comparison between the treatments, which might include no treatment. This is like a person standing on a platform and claiming that they are taller than another person, even though they are of the same height. Similarly, because of the way that research is designed, one treatment may appear more beneficial than another despite absence of any benefit. The second major error is the random error. This is the error that occurs by chance. This is like getting 4 heads and 6 tails, or 6 heads and 4 tails when you toss a coin 10 times, when the expectation is that you get 5 heads and 5 tails, despite no attempts to cheat. As the number of coin tosses increase, you get closer to 50% heads and 50% tails. Similarly, in a clinical trial, when the number of participants is few, the treatment effect may be different from the truth despite the comparison being a fair comparison. A concept related to random error is 95% confidence intervals. The 95% confidence intervals provide an estimation of the random error. They provide an estimation of what the treatment effect will be if the research was repeated in a different sample of trial participants similar to those in the research. In the absence of systematic error, there is only a 5% chance that the average treatment effect is outside the 95% confidence intervals. To summarize, the average treatment effects may not be accurate for the individual patient. There is uncertainty about how best to communicate evidence to patients, particularly whether one should communicate uncertainty in information to patients and how this should be done. I have developed a new app called Equal Pet, which is easily customizable for different illnesses. This can take the individual characteristics, disease characteristics, and healthcare provider characteristics into account when predicting the treatment effect. It also has different formats for presenting the information. Bar chart is one of the most easily understandable formats for communicating evidence to patients. However, bar charts do not communicate the uncertainty in information because of random errors. Equal Pet has options to present the 95% confidence intervals of the personalized treatment effects, although previous research has shown that presenting uncertainty in information can increase patients' anxiety and worry. However, uncertainty in information should be taken into account in order to make the correct decision. The 95% confidence intervals can be an optional additional format once the patients and their loved ones have overcome the initial shock of the diagnosis to understand the comparative benefits and harms of treatments personalized to them. Equal Pet can be connected to data stored in the server. If connected to an appropriate source, personalized treatment effects can be obtained without the need to share the individual data. We are conducting a survey to find out more about the need, usability, and potential extensions to the application. In terms of need, will the patients and loved ones find it useful to make decisions about their care if personalized treatment effects, accounting for their individual, disease, and hospital provider characteristics are presented to them? In terms of usability, currently the app is designed for use by patients alongside healthcare providers as part of shared decision making. We can redesign the app to allow the patients, survivors, and loved ones to use the app in the absence of a healthcare provider. Is this desirable? In terms of planned extensions, one possibility is presenting information about the likelihood of having a disease or condition based on the results of single or multiple tests and taking the individual characteristics into account. Another potential extension is a mobile app. Do you think that such extensions will be useful? Or condition based on the results of single or multiple tests and taking the individual characteristics into account. Another potential extension is a mobile app. Do you think that such extensions will be useful?